Hello everyone, this is Dr. Sam, and today we learn how to write ultrasound reports regarding neonatal brain pathologies. We will start by looking at a normal brain ultrasound case in an infant. You will learn how to write the findings and the impression for each case. There are many ways of writing reports, so these will be just one of the examples of writing reports. Let's start with the first case. The report begins with patient information, age, day 3 of life. Indication, routine screening for preterm infant or evaluation of intracranial anatomy. Next, we will write the technique. High-resolution cranial ultrasound performed via anterior fontanelle in coronal and sagittal planes. Additional images obtained through mastoid fontanelle. Now, we can move on to the findings. We can either write the entire findings like a paragraph, or we can divide it into different sections such as this. We can write about the ventricles and other parts as separate bullet points. Ventricles. Lateral, third, and fourth ventricles are normal in size and configuration. No evidence of ventriculomegaly. Then we can write about the germinal matrix. Germinal matrix. No echogenic foci or lesions to suggest germinal matrix or intraventricular hemorrhage. After that, we can write about the brain parenchyma. Parenchyma. Cerebral hemispheres show normal echogenicity and architecture. No cysts, masses, or focal abnormalities identified. Midline structures. Caevum septae pellucidae present and normal. Corpus callosum appears intact. Posterior fossa. Cerebellum and cerebellar vermis are normal in size and echo texture. No signs of hemorrhage or malformation. Extraaxial spaces, normal for age without abnormal fluid collections. Finally, we can end the report with the impression. Normal neonatal cranial ultrasound. No evidence of hemorrhage, structural abnormality, or hydrocephalus. So this is an example of a normal neonatal brain ultrasound report. Now we will look at the pathologies. Our first pathology is hydrocephalus, in which there is ventriculomegaly due to abnormal buildup of CSF. Age is 3 days, and clinical indication is increasing head circumference, full anterior fontanelle. Evaluate for intracranial pathology. This is the technique. Real-time cranial ultrasound performed through the anterior and mastoid fontanelles using high-frequency linear and sector transducers. Images obtained in coronal and sagittal planes. These are the findings of the ventricular system. There is marked dilation of the lateral ventricles as well as the temporal horns, which appear prominently expanded bilaterally. The frontal horns are rounded, and the third ventricle is mildly enlarged. The fourth ventricle is normal in size and configuration. You can write here whether the dilation is mild, moderate, or severe. Here are the findings of the brain parenchyma. Cerebral parenchyma appears preserved with no evidence of hemorrhage. No periventricular echogenicity suggestive of evolving periventricular leukomalacia. No focal mass lesions identified. No germinal matrix hemorrhage is seen. No intraventricular echogenic debris to suggest active hemorrhage. Extraaxial spaces, normal. No subdural or epidural fluid collections. Corpus callosum and midline structures. Midline structures are intact. Corpus callosum visualized and grossly normal. Cavum septum pellucidum present. Posterior fossa, cerebellum and brainstem appear normal. This is the impression. Hydrocephalus with prominent dilation of the temporal horns, consistent with obstructive or post-hemorrhagic ventricular enlargement. No intracranial hemorrhage identified on this study. Recommend correlation with clinical findings and consideration of MRI for further evaluation if clinically warranted. In a grade 1 germinal matrix hemorrhage, there is a mild bleeding in the highly vascular germinal matrix in the brain in premature infants. The patient's age is 2 days. Indication, prematurity, 32 weeks gestation, evaluate for intracranial hemorrhage. Here are the findings of the germinal matrix. Small, symmetric echogenic foci are noted within the caudothalamic grooves bilaterally. The areas of increased echogenicity measure approximately 3 to 4 millimeters on each side. No extension into the ventricular system is identified. Lateral ventricles are normal in size and configuration. No intraventricular hemorrhage or ventricular dilatation. Cerebral parenchyma demonstrates normal echo texture. No evidence of periventricular leukomalacia or cystic changes. Extraaxial spaces, normal. Other findings. Posterior fossa structures appear unremarkable. This is the impression. Grade 1 bilateral germinal matrix hemorrhage. No intraventricular extension or hydrocephalus. Recommend routine follow-up ultrasound in 7 to 10 days or sooner if clinical status changes. Now we will look at the report of Grade 2 germinal matrix hemorrhage. Age, 3 days. Indication, prematurity, screening for intracranial hemorrhage. In findings, there is no evidence of ventriculomegaly. On the left, there is a well-defined echogenic focus located at the caudothalamic groove, measuring approximately 6 millimeters in greatest dimension. This echogenic focus extends into the adjacent ventricular lining without distension of the lateral ventricle, consistent with Grade 2 germinal matrix or intraventricular hemorrhage. Right hemisphere. Hemorrhage identified, though less pronounced than the left. Extraaxial spaces. Normal. Cerebellum or posterior fossa. Normal morphology. No hemorrhage visualized. This is the impression. Grade 2 left germinal matrix hemorrhage with intraventricular extension without ventricular enlargement. No parenchymal hemorrhage. Recommend follow-up cranial ultrasound in 5 to 7 days to assess for evolution or development of post-hemorrhagic ventricular dilatation. Now we study the report of Grade 3 GMH. Patient age is 3 days. Gestational age at birth was 28 weeks. Indication, evaluation for intracranial hemorrhage in a preterm infant with increasing apnea and anemia. These are the findings. There is echogenic blood noted within the germinal matrix region adjacent to the caudothalamic groove on both sides, more pronounced on the right. Intraventricular extension of hemorrhage is present. The right and left lateral ventricles are moderately dilated, with thick echogenic layering clot along the dependent portions. Parenchyma. No definite periventricular cystic changes or evidence of parenchymal hemorrhage at this time. No midline shift. Posterior fossa, cerebellum, and posterior fossa structures appear within normal limits for gestational age. Grade 3 germinal matrix intraventricular hemorrhage, more pronounced on the right, with associated ventriculomegaly. No definite parenchymal extension identified on this examination. Suggest follow-up ultrasound in 3 to 5 days to assess for evolving ventriculomegaly or post-hemorrhagic hydrocephalus. This is a case of Grade 4 germinal matrix hemorrhage. Patient's age is 3 days. Clinical indication, preterm infant with apnea and bradycardia. Evaluate for intracranial hemorrhage. Here are the findings. Germinal matrix. On the left, there is a large hyperechoic collection centered in the germinal matrix region with extension into the lateral ventricle. On the right, a smaller but distinct hyperechoic focus is also present in the germinal matrix with intraventricular extension, though less extensive than on the left. Left lateral ventricle is significantly filled with irregular echogenic material consistent with intraventricular blood. Right lateral ventricle shows mild to moderate enlargement with echogenic debris. No evidence of midline shift at this time. Parenchyma. On the left periventricular region, there is an area of hyperechogenicity extending into the adjacent white matter, compatible with parenchymal involvement. The right hemisphere parenchyma also has clear evidence of hyperechogenicity extension. Posterior fossa is normal in appearance. This is the impression. Grade 4 germinal matrix intraventricular hemorrhage on the left with parenchymal extension and marked ventricular dilation. Presence of germinal matrix intraventricular hemorrhage on the right, less extensive than the left. Close clinical and sonographic follow-up recommended to monitor ventricular size and evolution of parenchymal injury. This is a report regarding a frontal horn cyst. Age, 3 days. Indication, prematurity, screening ultrasound to evaluate for intracranial abnormalities. Here are the findings. The ventricular system is normal in size and configuration for age. Within the left frontal horn, there is a well-circumscribed anechoic cystic structure measuring 4.5 into 3 millimeters. The cyst demonstrates thin, smooth walls, no internal septations, and no associated echogenic debris. No evidence of intraventricular hemorrhage. Periventricular white matter echogenicity is normal and symmetric. Posterior fossa structures are unremarkable. No extraaxial fluid collections identified. Here is the impression. Small, right frontal horn cyst. Most consistent with a benign periventricular pseudocyst. No ultrasound evidence of hemorrhage or hydrocephalus. Recommend routine follow-up ultrasound in 4 to 6 weeks to assess for interval resolution or stability. Here is a report of Chiari II Malformation. Patient's age is 2 days. Indication macrocephaly, concern for congenital malformation. Findings. Lateral ventricles are markedly dilated with colpocephaly and prominence of the frontal and occipital horns. The fourth ventricle is enlarged and appears inferiorly displaced relative to expected anatomic position. Third ventricle widened. Downward displacement of the fourth ventricle and cerebellar vermis is noted. Cisterna magna is not visualized, consistent with obliteration of the normal retrocerebellar CSF space. Inferior cerebellar structures appear crowded at the foramen magnum. Thalami, or midline structures. A large and prominent massa intermedia is present, bridging the thalami. Parenchyma. Supratentorial brain parenchyma shows normal echogenicity without focal hemorrhage. No extraaxial fluid collections identified. Doppler. Color. Doppler demonstrates normal flow in major intracranial vessels. Findings are consistent with Chiari II malformation, including colpocephaly, inferior displacement of posterior fossa structures, obliterated cisterna magna, and ventriculomegaly involving the lateral and fourth ventricles. The prominent massa intermedia is a reported associated feature. Recommend correlation with MRI of the brain and spine for comprehensive evaluation of hindbrain and spinal anomalies. Agenesis of corpus callosum is a congenital condition where the structure connecting the brain's left and right hemispheres, the corpus callosum, is completely or partially missing. Here is an example report. Age, 3 days. Indication, evaluation for macrocephaly and abnormal prenatal imaging. Findings. Lateral ventricles show colpocephaly with prominent dilation of the occipital horns and parallel orientation of the lateral ventricles. Mild prominence of the third ventricle. Fourth ventricle appears normal. Midline structures. High riding third ventricle noted. Brain parenchyma. No focal parenchymal lesions or hemorrhage identified. Echogenicity, appropriate for age. Cerebellum and cisterna magna appear normal. No evidence of Dandy-Walker malformation. No extraaxial fluid collections. No midline shift. This is the impression. Ultrasound findings are consistent with agenesis of the corpus callosum, characterized by colpocephaly, parallel lateral ventricles, and high-riding third ventricle. No evidence of intraventricular hemorrhage or other major structural abnormalities on this study. MRI of the brain may be obtained for further anatomical characterization if clinically indicated. Here is a report regarding a choroid plexus cyst. Age is 3 days. Indication: routine screening ultrasound for a preterm infant, evaluation for intracranial abnormalities. These are the findings of the choroid plexus. Right side: a single, well-circumscribed anechoic cystic focus is noted within the right choroid plexus of the lateral ventricle, measuring 4 millimeters in maximal dimension. No internal septations, debris, or vascular flow on color Doppler. Left side: choroid plexus appears normal with no cysts. Due to repetition, the other normal findings are excluded in this report, but they are written in the same way as shown in the previous reports. This is the impression. Small right choroid plexus cyst 4 millimeters. A common benign finding in neonates. No associated abnormalities identified. Otherwise, normal cranial ultrasound for age. No immediate follow-up required if clinically well. Consider repeat ultrasound in 4 to 6 weeks if there are ongoing neurological concerns or per referring clinician's preference. Here's a case of bilateral choroid plexus lipoma, a rare benign congenital malformation. Patient is a neonate, age 3 days. Indication: evaluation for macrocephaly noted on routine newborn exam. No abnormal neurological signs. These are the findings. Echogenic, well-circumscribed nodular structures identified within the atrial regions of both lateral ventricles, measuring 8 millimeters in the right and 7 millimeters in the left. Lesions demonstrate homogeneous hyperechogenicity with posterior acoustic shadowing, consistent with fat-containing tissue. No associated cysts, calcifications, or internal vascularity noted on Doppler. These findings are most compatible with bilateral choroid plexus lipomas, a rare benign congenital anomaly. Here is the impression. Bilateral choroid plexus lipomas, likely congenital and incidental. These are benign fat-containing lesions and typically asymptomatic. No evidence of intracranial hemorrhage, hydrocephalus, or other structural brain abnormality. This is a report example of Dandy-Walker malformation. Patient age is 3 days. Indication: macrocephaly, concern for posterior fossa abnormality. These are the findings. There is marked enlargement of the cisterna magna, measuring approximately 13.4 millimeters in anteroposterior diameter, consistent with a significant posterior fossa fluid collection. The cerebellar vermis is completely absent, with no identifiable midline cerebellar tissue bridging the hemispheres. The cerebellar hemispheres are present but separated by a trapezoid-shaped midline gap, widening toward the dorsal posterior fossa. The superior and inferior margins appear sharply delineated. The fourth ventricle is enlarged and contiguous with the posterior fossa cystic space, without discernible vermian coverage. Here is the impression. Ultrasound findings are highly suggestive of Dandy-Walker malformation, characterized by marked enlargement of the cisterna magna, complete vermian agenesis, trapezoid-shaped separation of the cerebellar hemispheres with communication to the enlarged fourth ventricle. Recommend MRI of the brain for further characterization of posterior fossa anatomy and evaluation for associated supratentorial anomalies. Close neurology and neurosurgical follow-up advised. Next, we will look at the report of Cisterna Magna. Patient is 2 days old. Indication is screening ultrasound for macrocephaly, evaluate posterior fossa. Here are the findings. The Cisterna magna is enlarged, measuring approximately 12 millimeters in AP diameter. Cerebellar vermis appears intact and normally formed, with no evidence of rotation or hypoplasia. Cerebellar hemispheres are normal in size and echogenicity. The fourth ventricle is normal in position and morphology. No signs of Dandy-Walker malformation or other posterior fossa anomalies. Here is the impression. Mild enlargement of the Cisterna magna, consistent with Cisterna magna. No associated structural abnormalities identified in the cerebellum or vermis. Ventricular size and brain parenchyma are within normal limits. Findings likely represent a benign anatomical variant. This is a report of Septo-Optic Dysplasia, the mildest form of holoprosencephaly. Indication is evaluation for brain anomaly. These are the findings. Midline structures. The cavum septum pellucidum is absent. No definable leaflets of the septum pellucidum are visualized on coronal or sagittal views. The lateral ventricles demonstrate mild, box-like frontal horns, which can be associated with absence of the septum pellucidum. This is the impression. Findings compatible with septo-optic dysplasia, including absence of the septum pellucidum. Recommend MRI of the brain and orbits for further characterization of midline structures, optic pathways, and pituitary morphology. Clinical correlation with endocrine function and ophthalmologic evaluation is advised. This is a report of Semilobar Holoprosencephaly, which is intermediate in severity. Patient age is day 1 of life. Clinical indication: abnormal prenatal neuroimaging. Evaluate for congenital brain malformation. Findings of the forebrain and midbrain. Findings consistent with Semilobar Holoprosencephaly. There is partial but incomplete separation of the cerebral hemispheres. The posterior parietal and occipital lobes demonstrate partial separation, whereas the frontal regions remain fused. A single, large ventricular cavity is present anteriorly with rudimentary partial interhemispheric division posteriorly. Falx cerebri is partially formed, noted only in the posterior aspect. Corpus callosum appears hypoplastic. A small posterior segment may be present, but is poorly defined. Thalami appear partially fused at the midline. Basal ganglia structures are difficult to distinguish. Cerebellum and brainstem are present and grossly normal in size and echogenicity. Fourth ventricle appears normal. Findings are consistent with Semilobar Holoprosencephaly, characterized by partial hemispheric separation, fused anterior structures, a single anterior ventricular cavity, partial falx formation, and thalamic fusion. Posterior fossa structures are preserved. Recommend correlation with MRI for detailed anatomical characterization and genetic clinical evaluation. Alobar Holoprosencephaly is the most severe form of holoprosencephaly. Age, day 1 of life study. Cranial ultrasound via anterior fontanelle indication. Abnormal prenatal imaging. Evaluate midline brain structures. Findings. There is complete absence of midline separation of the cerebral hemispheres, with a single, large, crescent-shaped supratentorial fluid cavity occupying the expected location of the lateral ventricles. Interhemispheric fissure, falx cerebri, septum pellucidum, and corpus callosum are not visualized. Thalami are fused at the midline with a continuous echogenic mass seen anteriorly. A single monoventricle is present, with smooth, continuous internal margins and no identifiable frontal or occipital horns. Third ventricle not separately identified. Cortical mantle. The cortical mantle appears markedly thinned but symmetric around the unified ventricular cavity. Cerebellum and brainstem show grossly normal echogenicity and morphology, though limited evaluation, secondary to technical constraints and overlying supratentorial abnormalities. This is the impression. Ultrasound findings are most consistent with Alobar Holoprosencephaly, characterized by complete failure of hemispheric division, absence of falx and midline structures, fused thalami, single monoventricular cavity, marked cortical mantle thinning, correlate with prenatal imaging and clinical evaluation. Further characterization with MRI may be considered if clinically appropriate. Now we have a case of open-lipped schizencephaly. Patient is a newborn, day 3 of life. Study: cranial ultrasound via anterior, posterior, and mastoid fontanelles. Indication: abnormal prenatal brain imaging. Evaluate for structural anomaly. Here are the findings. Left cerebral hemisphere. A well-defined cleft extending from the cortical surface to the left lateral ventricle is present. The cleft is fluid-filled with widely separated, open-lipped margins, consistent with open-lipped schizencephaly. The walls of the cleft demonstrate smooth lining, though visualization is partially limited by patient motion. Surrounding parenchyma shows mild thinning but preserved echogenicity. Corpus callosum, partially visualized, appears thinned anteriorly but continuous. Posterior fossa, cerebellum symmetric, no hemorrhage or malformation detected. This is the impression. Findings consistent with left open-lipped schizencephaly. No evidence of intraventricular or parenchymal hemorrhage. Correlate with prenatal imaging. Consider brain MRI for comprehensive evaluation of cortical organization, associated migrational abnormalities, and evaluation of corpus callosum. This is a case of close-lipped schizencephaly. Patient, age 3 days. Indication: evaluation for abnormal tone and asymmetric limb movement. No history of trauma. These are the findings. The ventricular system is normal in size and configuration. No evidence of intraventricular hemorrhage. Along the right cerebral hemisphere, extending from the ependymal surface of the lateral ventricle, there is a narrow, horizontally oriented cleft. The cleft does not communicate with the subarachnoid space. No associated parenchymal hemorrhage, mass effect, or abnormal extraaxial fluid collection is seen. Cavum septum pellucidum is present. Corpus callosum visualized and appears mildly thinned but intact. Doppler assessment shows normal arterial and venous flow patterns. Here's the impression. Right-sided, closed-lipped schizencephaly, characterized by a tightly opposed cleft, extending from the right lateral ventricle to the cortical surface without open communication. No acute intracranial hemorrhage or hydrocephalus identified. Recommend follow-up MRI for detailed cortical and white matter evaluation and to assess for associated migrational anomalies. Here is a report about Lissencephaly. Patient age is 3 days. Indication: hypotonia, poor feeding, abnormal neonatal exam. These are the findings. Cerebral cortex, markedly smooth cerebral surface with absence of normal sulcation. gyral pattern, paucity of gyri throughout both cerebral hemispheres. Overall appearance suggests ageria or pachygyria spectrum. Parenchyma, homogeneous echogenicity without focal lesions. Ventricles, mild ventriculomegaly. Lateral ventricles appear rounded with diminished visualization of normal periventricular landmarks. Corpus callosum, present but appears thin on midline sagittal views. Posterior fossa, cerebellum, and brainstem structures appear within normal limits. No intracranial hemorrhage identified. Ultrasound findings are highly suggestive of Lissencephaly with markedly reduced cortical sulcation and thickened cortical mantle. Mild secondary ventriculomegaly noted. Recommend follow-up MRI for definitive characterization of cortical malformation and evaluation for associated structural abnormalities. Here is an example report of Hydranencephaly. Age, 3 days. Indication, evaluation of abnormal head growth and poor neurological responsiveness. Concern for congenital intracranial abnormality. Findings: near complete absence of the supratentorial cerebral hemispheres. The intracranial cavity is largely replaced by a single, large anechoic fluid-filled space consistent with cerebrospinal fluid. Thin residual rims of cortical tissue are not clearly visualized. Falx cerebri. Falx is present but markedly thinned. Midline structures. Thalami and brainstem structures are present and appear grossly preserved. The third ventricle is not clearly delineated. Posterior fossa. Cerebellum appears intact and normal in echogenicity and morphology. Fourth ventricle visualized and normal in configuration. Lateral ventricles are not separately identified due to replacement of cerebral hemispheres by fluid. No discrete intraventricular hemorrhage is seen. Ultrasound findings are highly suggestive of hydranencephaly, characterized by near-complete absence of the cerebral hemispheres, with preservation of midline and posterior fossa structures. Recommend correlation with clinical findings and consideration of MRI for further anatomic detail. Here is a report about Cystic Encephalomalacia, age 12 days, clinical indication, evaluation for possible hypoxic ischemic injury or abnormal neurologic examination. Findings: there is diffuse cystic encephalomalacia involving both cerebral hemispheres. The parenchyma demonstrates multiple irregular cystic cavities of varying size scattered throughout the paraventricular and subcortical regions. Several of the larger cystic spaces show thin internal septations with partial compartmentalization. The surrounding brain tissue appears markedly thinned, consistent with parenchymal loss and gliosis. The ventricular system is mildly enlarged, likely reflecting ex vacuo dilation. No intraventricular hemorrhage or focal mass lesion is identified. Findings consistent with cystic encephalomalacia, characterized by multiple cystic regions with internal septation formation, suggestive of remote severe hypoxic ischemic or ischemic insult. Correlation with clinical history and consideration for follow-up MRI are recommended for further evaluation. Our next case is aqueductal stenosis. Indication: increasing head circumference. Concern for hydrocephalus. Lateral ventricles, markedly dilated bilaterally with rounded margins. Ventricular atrial width is increased. You can write the size of the ventricles here. Third ventricles, dilated and prominently visualized, consistent with obstruction at or distal to the aqueduct. Fourth ventricle, normal in size and configuration, no evidence of dilation. Parenchyma, Cerebral parenchymal echogenicity is normal without focal lesions or hemorrhage. Posterior fossa, normal appearance. Here is the impression. Ultrasound findings are consistent with aqueductal stenosis, evidenced by dilation of the lateral and third ventricles with a normal appearing fourth ventricle. No associated abnormalities identified. Correlate with clinical status. Consider MRI brain for further characterization and evaluation of obstructive hydrocephalus. Here's a case of subarachnoid hemorrhage. Indication: evaluation for intracranial hemorrhage in the setting of abnormal neurologic exam. Findings: within the posterior fossa, there is a prominent hyperechoic collection localized around the cerebellum, most conspicuous in the cisterna magna and adjacent posterior fossa soft tissues. This collection demonstrates irregular margins and heterogeneous internal echogenicity, consistent with acute subarachnoid hemorrhage. The cerebellar hemispheres and vermis show preserved architecture without mass effect or parenchymal involvement. No definite extension into the fourth ventricle is identified. The cisterna magna appears partially effaced by the echogenic material, though the brainstem remains normally visualized. No obvious hydrocephalus or secondary signs of increased intracranial pressure are present at this time. Hyperechoic hemorrhagic material in the cisterna magna and surrounding posterior fossa subarachnoid spaces compatible with posterior fossa subarachnoid hemorrhage. No intraventricular hemorrhage or cerebellar parenchymal hemorrhage identified. No hydrocephalus at the time of examination. This is a sample report about Periventricular Leukomalacia. Age: 2 days indication. Prematurity: evaluate for periventricular injury. These are the findings. Symmetric hyperechoic regions identified in the periventricular white matter bilaterally, more prominent adjacent to the frontal horns. No cystic changes are observed. No intraventricular hemorrhage identified. Cerebellum and posterior fossa structures appear unremarkable. No midline shift or extraaxial fluid collections. Impression: Grade 1 Periventricular Leukomalacia. Presence of bilateral periventricular echogenicity without cyst formation, compatible with early non-cystic PVL. Follow-up cranial ultrasound in 1 to 2 weeks to monitor for evolution of cysts or resolution of hyperechogenicity. Consider clinical correlation with neurological status and risk factors related to prematurity. Here is a report for Grade 2 Periventricular Leukomalacia. Age: 4 days indication. Prematurity: evaluation for intracranial pathology. These are the findings. Bilateral periventricular regions demonstrate increased echogenicity compared to adjacent white matter. Multiple small, discrete cystic spaces are identified within the periventricular white matter, most prominently adjacent to the frontal horns and body of the lateral ventricles. No parenchymal hemorrhage or focal mass effect. Posterior fossa structures appear normal. Cerebral sulcation appropriate. This is the impression. Findings consistent with Grade 2 Periventricular Leukomalacia, characterized by the formation of multiple small periventricular cysts within bilateral periventricular white matter. Recommend follow-up imaging to monitor cyst evolution and progression. Consider neurological and developmental follow-up. Now we move to Grade 3. Periventricular Leukomalacia. Gestational age was 32 weeks and postnatal age is 10 days. Indication: prematurity, concern for hypoxic ischemic injury. These are the findings. Marked increased periventricular hyperechogenicity is seen bilaterally, most prominent along the frontal and parietal periventricular white matter. There is an increasing number of well-defined cystic areas within the previously noted hyperechoic regions. These cysts measure between 2 to 6 millimeters in diameter and are distributed along the periventricular zones, consistent with cystic white matter degeneration. No midline shift or extra-axial fluid collections observed. This is the impression. Findings are consistent with grade 3 periventricular leukomalacia, characterized by extensive periventricular hyperechogenicity and evolving multiple periventricular cysts, indicating established white matter necrosis. Serial follow-up imaging in 2 to 4 weeks to monitor progression and multidisciplinary evaluation, including neurology and developmental services, are recommended. Grade 4 is the most severe form of periventricular leukomalacia. Indication: prematurity and concern for hypoxic ischemic injury. Here are the findings. There is increased periventricular hyperechogenicity bilaterally, consistent with ongoing white matter injury. Multiple larger cystic lesions are noted within the periventricular and subcortical regions. The cysts are predominantly along the lateral ventricles and appear well-defined. Ventricles. Lateral ventricles are mildly prominent, but without overt hydrocephalus. Basal ganglia, thalami, brainstem, cerebellum appear normal in echo texture. No focal hemorrhage detected. Impression. Findings are consistent with grade 4 periventricular leukomalacia, characterized by extensive periventricular white matter injury and larger cyst formation. Suggest clinical correlation and follow-up imaging to monitor cyst evolution and assess for potential neurodevelopmental sequelae. This is a case of cerebral edema. Here is the report. Patient is a neonate, 3 days old. Indication: prematurity with respiratory distress. Rule out intracranial pathology. Here are the findings. Brain parenchyma. There is generalized increased echogenicity noted throughout the cerebral hemispheres, more pronounced in the periventricular regions. The normal fine cortical and subcortical differentiation appears coarsened. Ventricles. Lateral ventricles appear slit-like. Third and fourth ventricles are not dilated. No intraventricular hemorrhage is identified. Cerebellum, mildly echogenic but otherwise structurally intact. Extra-axial spaces, no significant subdural or subarachnoid collections. Here's the impression. Findings are suggestive of cerebral edema with diffuse parenchymal involvement. The slit-like ventricles and coarsened parenchymal echo texture support increased intracranial pressure. No evidence of hemorrhage at this time. Correlation with clinical status and neurologic examination. Consider follow-up ultrasound or MRI to monitor evolution of cerebral edema. Monitor for seizures and other neurologic complications. This is a report about ventriculitis. Here are the findings. Lateral ventricles, markedly abnormal. Both ventricles are distended and contain extensive internal echogenic debris and fibrinous clots, causing irregular intraventricular architecture. Multiple thick septations traverse the ventricular cavities, with reduced visualization of normal CSF spaces. Third ventricle, dilated, similar heterogeneous echogenic material evident, filling much of the ventricular lumen with internal septations. Fourth ventricle is also filled with echogenic debris and clot, demonstrating diminished fluid signal and internal compartmentalization. Ependyma. The lining of the lateral and third ventricles is echogenic and thickened, consistent with ependymal edema or inflammation. No normal smooth ventricular borders are seen. Adjacent parenchyma. No focal intraparenchymal hemorrhage is definitively visualized. However, mild increased periventricular echogenicity may reflect reactive changes or immature white matter. Cerebellum. Grossly unremarkable. No discrete hemorrhagic foci identified. Severe ventriculitis involving the lateral, third, and fourth ventricles, characterized by extensive septations, intraventricular echogenic clot or debris, and marked thickening, edema of the ependyma. Findings are compatible with advanced inflammatory or post-hemorrhagic ventricular organization. Recommend correlation with CSF studies and consideration of MRI for further characterization. This is our final case, meningitis. This is the report. Findings: suprasellar cisterns demonstrate diffuse thickening and increased echogenicity, suggesting inflammatory involvement of the basal cisterns. The cisterns are less well delineated than expected for age. Meninges: global meningeal thickening with mildly irregular margins. The leptomeningeal surfaces show increased echogenicity, particularly along the frontal and parietal convexities, compatible with inflammatory change. Multiple sulci are markedly hyperechoic and thickened, with loss of the typical thin, linear appearance. This finding suggests meningitic exudate or inflammatory debris within the sulcal spaces. Small to moderate extra-axial fluid accumulations are present bilaterally, more pronounced over the convexities. No midline shift identified. Fluid demonstrates low to moderate echogenicity, potentially reflecting early infectious or proteinaceous content. Overall cortical and subcortical echo texture remains preserved. No focal parenchymal lesions or intraventricular hemorrhage identified. Ventricular size within normal limits for age. No evidence of hydrocephalus. This is the impression. Ultrasound findings of meningeal thickening, hyperechoic sulci, and extraaxial fluid accumulation, along with thickened suprasellar cisterns, are highly suggestive of neonatal meningitis, likely bacterial in etiology. Recommend urgent clinical correlation and further diagnostic evaluation, including lumbar puncture and MRI if clinically feasible. So these are examples of how to write ultrasound reports regarding neonatal brain pathologies. Thank you so much for watching. Stay tuned for more imaging videos.